Welcome, East Coast, West Coast, and to everyone watching us around the world. My name is Adrian Dan, and on behalf of the American Society of Metabolic and Bariatric Surgery, Bariatric Surgical Training Committee, I welcome you to another edition of the Fellows Project. We've got a great one for you today, but before we get going, just a couple housekeeping announcements. If you're a fellow, welcome to the Fellows Project. Hope you're taking advantage of these great events that we're putting together, but also make sure you log on for the happy hour. If you weren't on last night, you missed a great one. Remember, all of these are available without password protection on the ASMBS website for anybody to watch, fellows, your colleagues, residents, staff, and anyone who you may feel may benefit from it. Also, the START program, our surgical technique and robotic training program. Webinars from that are available on the ASMBS YouTube channel. Begin looking at your application for certification of additional training from the ASMBS. This is the time to get the materials together and start looking at the things that you have to provide. Also, make sure your case logs are up to date so that when it comes time for that application, it's already to go. So today we've got a great set of lectures for you with two really influential speakers and well-known individuals within our specialty. I'm going to start with Dr. Eric DeMaria, who is now the department chair. This is a new development, professor and chief of general and bariatric surgery at Brody School of Medicine at East Carolina University. Congratulations, Eric, on the new appointment. But for those fellows who may not know Dr. DeMaria, he is also past president of ASMBS and remains one of the most impactful and influential members of our society. We are really lucky to have him here today. He's also been an author, put together multiple and numerous book chapters and articles, including one on the claims that bariatric surgeons tend to face in medical legal challenges. Also joining us today is Dr. Emma Patterson. Dr. Patterson is in Portland, Oregon, and we have to acknowledge the fact that it's barely 4 a.m. there. So thank you, Emma, for joining us. Dr. Patterson is a globally recognized leader in metabolic and bariatric surgery. She's highly active, a highly productive and respected member of ASMBS, and has devoted her whole life and career to increasing patient safety with our procedures. Also, I want to wish Dr. Patterson a happy birthday today.
Thank you.
Sing later, Emma. But I do want to say that, our speakers are fantastic. They really need no introduction. And when you have stuff named after you, you know that you've contributed a lot. And I remember as a fellow and early in my career using the DeMaria mortality risk scoring system, which has really improved our ability to understand what puts people at higher risk. And Emma, I remember as a fellow being taught the Patterson stitch on the gastric band. Even though it's something we don't do much anymore, I always remember the Patterson stitch. So with that, I will welcome you guys, and I'll also tell our audience of fellows that I'm gonna quote the great Walter Porres when he says, "Look, there's a way to not get complications, and that's to just stop operating." But until then, complications in bariatric surgery are a fact of life. They're a reality. And you guys are going to help us understand today that if they are a necessary evil, how do we manage that risk? How do we keep ourselves out of the courtroom? So we'll start with Dr. DeMaria.
Great. Thank you, Dr. Dan, Dr. Eckhouse. Really a great pleasure to be here. I hope everybody can see my slides. I just shared them. So we're going to talk about staying out of the courtroom, the issue of medical malpractice after bariatric surgery. And specifically, we're going to focus on a study that we did that Dr. Dan mentioned, which is lessons learned from closed claims in bariatric surgery. Okay, I have no disclosures that are relevant to today's topic. Obviously, no one ever wants to hear that a medical malpractice claim was filed against them. But that's really what we're talking about today, and a study of what that means, and a lot of detail that we could get into here, but we're going to cover, major topics and issues that can lead to claims so that people are aware. So if you go back to the 80s and early 90s, the study of errors in medicine became very widely publicized. Errors really imply negligence or deviation from the standard of care. There were very high-profile reports from the Institute of Medicine talking about the frequency of errors in medical care. And obviously the result was tremendous interest in studying quality and analyzing outcomes. But there was slow progress, in part because people were afraid to talk about errors, fear of litigation, fear of censure by their own institutions. So near misses, adverse events, and other errors were difficult to come by. And I think Dr. Tom Russell, who's the former executive director of the college, said it well, that there are things that occur in patient care sometimes that are really only revealed in the files of insurance companies. In other words, we have the medical record and we have the perspective of the care providers, but we generally don't have the perspective of the patient, the patient's family, and so forth. And that really does come out in claims where the insurance does report those types of issues. So the college became involved in the study of closed claims a number of years ago. They looked at 460 claims, over $25,000 in payments, and had 40 surgeon reviewers look at these claims from 5 medical liability companies. These claims were closed about 20 years ago, so this is somewhat historic by this point in time. But they learned a number of things. There were 22% of claims involved pre-op management. Most deficient event was post-op in 31%. Organ injuries, interestingly, motivated claims in 40% of cases, but in only 12% was the most deficient aspect of patient care. And we're going to get into that a lot. In other words, for example, injuring a spleen during an operation, that would be an organ injury, but was not judged to be the most deficient part of surgeon performance, which is interesting. Failures in practice patterns, so this is what the college papers call this, practice patterns or behaviors. They noted failure to communicate was the most pervasive issue and probably accounting for 1/5 of all complication events. And then more than half of claims involve communication failures. And this theme will become more and more clear as we talk through bariatrics. But they, in this paper by Dean Griffin, who actually was a consultant to the ASMBS, as well as Karen Posner, co-authors on this paper, talk about detrimental behavior patterns causing deficiencies in care, a lack of diligence, vigilance, or commitment of time, more than a lack of knowledge or skill in terms of leading to claims. And then the quote, technical failures on the part of surgeons are accepted with humility and maybe within the standard of care in certain circumstances, but behavioral failures are not. And that theme comes true more and more as we go through this information. Now, there's only a handful of studies that look at bariatric surgery claims, and this is one of the more recent ones, which is why I've included it. 140 cases. Interestingly, several studies show a predominance of male patients involved in claims, and then an average patient age of 43, pretty typical for bariatric surgery. The most common procedure is a Roux-en-Y bypass in this study. Most common reason for claim was a delay in diagnosis or management of a complication of the postoperative period, nearly 50%. Most common allegation was failure to appropriately manage a post-op bowel leak in a timely manner, a full 1/5 of cases. Death was a motivator for families to file litigation, and death was reported in about half of all the cases. So these are pretty extreme outcomes. And then this is very important for us to bear in mind. Nearly half of the cases were decided in favor of the plaintiff patient. The median award payout was over $1 million. Interquartile range, this is the median 50% of dollars paid, from 400,000 to 2.5 million. The median sum when settled before trial or in favor of the plaintiff was over $5 million. And then in terms of the range of payouts, a staggering $178 million in one case, which is really a very dramatic high number. You might ask why so much money paid out in claims. Typically, young plaintiffs with permanent disability requiring dependent care for the rest of their lives is a scenario that's very relevant. And I think we're going to talk about more when Dr. Patterson talks about her topic. So we got together with the ASMBS Quality Improvement and Patient Safety Committee and formed a closed claims task force where we went to 4 different medical malpractice carriers and reviewed cases. 2 surgeons reviewed each case, and then we had multiple discussions to judge the cases and to try to classify them. The good news is that the defense prevailed in nearly 2/3 of the 162 claims reviewed. These claims were closed between 2010 and 2015. And while that may seem like old news, maybe out of date information, you have to remember that claims percolate for years before they're ever closed. So that's the nature of the beast. It takes a while to get to the point where we can look at them. So 37% of claims received monetary awards ranging from $20,000 to a high of $8 million in our study, averaging about $300,000 when there is a payment made. And then don't forget that the expense of the lawsuit, even if the defense prevails, is high. This in 10-year-old dollars, $90,000, but in fact today is probably double or more that amount of money. So they're expensive to defend claims, even if you prevail. Here are issues that were related to the closed claims that we reviewed in this study: mortality in fully 1/3 or more of patients, leak in nearly 20%. That is a constant theme in bariatric surgery claims. Leak can lead to filing a lawsuit. Bowel obstruction was a surprisingly high number at nearly 10%. Bleeding, 5%. Retained foreign body, sponges left inside, instruments left inside in about 5% of cases. Vascular injury, typically referred to access injuries in laparoscopy, central vascular in particular. And then some things that really weren't much of a problem in terms of causing claims were things like ulcers, nausea, MI, things like that. So, and then the panel of authors judged the claims in terms of things like preventability by the surgeon. And this is an impressive statistic. Over 50% were felt to have preventable characteristics if surgeons had acted differently in managing the patients. Preoperative care phase was generally not an issue. Felt to be not an issue in 2/3 of cases. So that's not really the focus of where claims tend to occur. And then would better post-op care have prevented the complication? That was about 45%. The panel felt that that was true. Better post-op care could have prevented the complication. And then cause determination, 50%, right about at that number, was felt to be provider related. About 25% system related, and about 20% disease related. So providers are clearly a focus here for prevention. We examined performance issues, and you can see the distribution of these across the bottom of the slide. Delay or inappropriate treatment was the highest frequency at 35%. Delay or inappropriate diagnosis was second at about 20 to 25%. And then incorrect performance of a procedure, 15%. And I give you an example of that, like creating a Roux-en-O limb instead of a Roux-en-Y, was in several cases. The appropriate clinical performance on the far right there with the red arrow was only at 12%. So clearly some concerns about performance issues. And then here are factors contributing to the complication. And these are such things as coverage or handoff availability, teaching hospital with trainee supervision, fatigue or distraction from workload issues, and informed consent. All the ones with a blue star are things that have likely involvement of communication deficiencies. And that was a prevailing message here, that communication was an important factor in terms of contributing to claims. So bear that in mind, and we're going to dive into that in more detail. So here are communication issues. First note on the right, the appropriate communication performance was really only seen in 18% of cases that we reviewed that had claims. And then you might think that the failure to document or to adequately inform patients with disclosure would be the more common issues. Well, these were relatively few, and insufficient communication with either the other members of the healthcare team or with patient and family members were much higher in terms of problematic issues in communication. So in order to reduce claims from this review, and future opportunities should be focused on the post-op care domain more than the pre-op care domain, failure to delay or diagnose issues, and delaying treatment. And clearly the issue of communication, just like in the college studies, comes out as a critical importance, particularly with the healthcare team, which is maybe not what you would expect when you first think about this issue. So let's sort of dissect the communication issue again, and let's talk about some scenarios that we could focus on to do better. Intraoperative issues, and I thought I'd pick on as an example our communication with staff in the room during operations, like anesthesia staff, nursing staff. Post-operative care issues, the issue of handoffs for coverage and how those are done, and then post-op patient phone calls and how they're handled. You know, every surgeon's office handles calls from patients, and how they're handled and what's done with those patients can contribute to communication issues. So let's talk first about intraoperative communication, the classic example of needing to remove the tubes from the stomach before you staple the stomach, communication with nursing, requesting an instrument and how to get that when you need it, and then things like need for blood when you need to transfuse the patient. Remember, the quality of communication is affected by distractions, and there are many distractions in our operating rooms. There's pages, phone calls, noise, music, sometimes socializing. Even teaching can interfere with people hearing communication. And so you have to bear these things in mind and make sure that you have the attention of the folks that you're trying to communicate with. So the classic example of needing to remove the NG tube before stapling the stomach, what we found in our review was that there were strategies talked about by the surgeons that probably didn't really measure up to what they should be. So things like saying, my anesthetist knows not to place an NG. I always notify the anesthetist to remove the NG, or my anesthetist knows to remove the NG. Well, each of these strategies can and did fail in these cases where the NG tube was stapled. So having new or unfamiliar personnel in the room, assuming knowledge or understanding without checking with the individual that you're communicating with, and then For example, and this is classic, I think there's tubes other than an NG tube that might be down in the stomach, like a temperature probe that's misplaced or some such thing. It's incorrect in our minds to just assign blame to the anesthetist at the head of the table. It's really the unclear communication that leads to the injury. So we need to bear that in mind and take some responsibility for what happens. So I'm going to give you an example of a construct for good communication with standardized speech, much the way airplane pilots communicate with standardized speech to avoid misinterpretation. So making eye contact, calling your anesthetist by name if you know their name, and saying something very formal, like I'm getting ready to staple the stomach and need all tubes and probes removed from the patient's nose and mouth except for the ET tube. And would you please confirm for me when all tubes and probes have been removed? Now, this may seem very formal in terms of communication, but I think it clearly conveys the message. It may seem a little silly if you work with somebody all the time that you have to be so formal, and maybe you don't. But just remember, sometimes a person at the head of the patient is not someone you've worked with before and may not really understand. The time I stapled a tube in the stomach was a CRNA student at the head of the table who assured me everything was out of the patient's nose and mouth, yet she left a temperature probe. And I didn't realize it until she realized her mistake and tried to pull it out after the stomach was already stapled. And I saw the stomach jumping around like a Mexican jumping bean as she tried to remove it. So confirmation also is very helpful with communication. That way you know you've been heard. Handoffs and sign-outs, handovers of patients. Much work has been done to standardize these as we improve quality, standardize the information communicated, and formats often include written sign-outs. But most of this work has been done with resident staff, but we observed issues beyond trainees. Partners were not aware that there were issues with a difficult case or a lack of trust or commitment in terms of one partner agreeing to manage a partner's patient when the partner was out of town. And then people being excessively pulled in many directions with multiple hospitals and not able to cover adequately. So written sign-out is always better than verbal, and it's useful to communicate what you are worried about with the patient and what might need to be done if such and such happens. It's a very important message that covering physicians must treat the patients as though they were the primary on the case, because that covering physician is liable for the coverage decisions they make. And we saw that fail in a number of cases. We saw cases where the operating surgeon who made an error was dismissed from the case because it was so clearly the covering surgeon that made the mistakes later on that caused the bad outcome. Patient phone calls to the office. It's important to know who handles them, what their level of training and decision-making are, even a written protocol for handling patient calls. Are calls returned promptly? You can be judged negligent for not promptly returning patient phone calls. And if you're tied up, does your staff have the authority to bring a patient in for you to evaluate? All these are key issues in phone calls with communication. And here's just one horror story from our review. This was a super obese male who went home on oxygen after a gastric bypass. The wife made multiple phone calls over 4 to 5 days, never spoke with a provider, only with staff. Then the patient developed green wound drainage and was told to keep his appointment for next week. Was never brought to the office, and the patient was found dead at home before that appointment in the office on post-op day 10. Now, another twist to this story that you have to remember, there was no autopsy in this case. So the plaintiff's attorney was free to offer many scenarios to possibly explain this outcome, like a pulmonary embolus, obviously, after a DVT, and even an intra-abdominal leak to explain the green drainage. And there was no proof that any of these things occurred, but that didn't stop the plaintiff's attorney from waxing poetic about how many possible explanations there were that suggested negligence on the part of the surgeon. And the surgeon did not prevail in this case, and there was a large payout for damages. So important to remember all these things. So to sum up, medical liability claims in bariatric surgery are costly, even if the defense ultimately prevails. And really, focus needs to be on avoidance of those claims. And liability claims clearly correlate with quality issues. And as we study and work to improve quality, it's a good strategy to study these claims. And there are high-risk scenarios that are more likely to lead to claims, even though these things occur at a low frequency and may not be avoidable. And I'll go back to Dr. Dan's citation at the beginning. You know, the saying is, if you're not having complications, you're not doing enough surgery. We all are going to have complications, but it's how you manage them really that determines whether or not the patient has a valid claim. So you may ask, how do I avoid having to defend myself in court? And one of the issues to think about and to spend time thinking about proactively is communication. And look at communication issues in your practice with attention to real and potential problems that can arise and solve them. Develop standard protocols for handling various care scenarios to optimize patient outcomes, including the examples we've talked about, like intraoperative essential communications, like getting those tubes out of the stomach, and post-op care, main ones, handoffs, coverage, and phone calls from our review of 162 bariatric surgery claims. So with that, thank you all very much. I have enjoyed being here and look forward to questions.
Thank you, Dr. DeMaria. No surprise from you that you had such an amazing talk that really hit on all the important aspects that we have to remember. Fantastic. I can't wait to hear some of the questions from our audience at the end. However, next we're going to move on to Dr. Emma Patterson. Increasing in frequency, along with the number of bariatric procedures that we've been doing, although rare, thiamine deficiency and Wernicke's encephalopathy can have tremendous consequences. So, Emma, I'm going to turn the virtual podium over to you to educate us on how do we treat this, how do we recognize it, how do we raise awareness about Wernicke's encephalopathy.
Thank you. That was excellent, Eric. Yeah, so I've been doing bariatric surgery a long time and doing expert work for now about 20 years, and particularly a lot in the last 5 years, and was noticing more and more Wernicke's cases, and these are devastating cases when it gets to Wernicke-Korsakoff. And so actually our president, Dr. Kurian, decided to start a Wernicke's task force at ASMBS, which I'm chairing, and Dr. Dan is on. And so our mission, and this is part of it, is to educate ASMBS members, other medical and nursing societies, and the public about thiamine deficiency and Wernicke's encephalopathy, as it is much more prevalent than previously thought. And ultimately, our goal is to help prevent Wernicke's encephalopathy and Wernicke-Korsakoff syndrome. And as bariatric surgeons, as the people who are altering someone's GI tract so that they can't eat much, we absolutely have to know about this. And so after this brief talk, I hope that you're going to understand that, minimize you guys, bariatric patients are at high risk of thiamine deficiency. What happened? Okay. List the Kane criteria for clinical diagnosis of Wernicke's and discuss the prevention and treatment and describe the long-term effects of Wernicke's. And of course, you will then be armed to stay out of the courtroom for these kind of cases too. So Wernicke's, of course, you know, is an acute neurologic syndrome caused by thiamine or vitamin B1 deficiency. And Wernicke's, you can call it Wernicke's or Wernicke without the S. Either way is accepted. And previously it was reported to be quite rare, like 0.4 to 2.8 per 100,000 population. And it turns out that's not true because in autopsy studies, suggests the prevalence is actually as high as 1 to 3% of the general population. And it's up to about 12% in alcoholics, where this condition is commonly known. And sadly, only 15% of cases are diagnosed prior to death. So this is something we want to change. And you probably remember the classic triad of Wernicke's are eye signs, confusion, and ataxia. But this classic triad is present in only 10% of patients with Wernicke's. So you can't be expecting to see this whole triad. And if you do, it is most definitely Wernicke's. And some of these signs are subtle. So the eye signs, they may or may not complain of blurry vision, double vision. But when you examine someone you suspect to be thiamine deficient, they will likely have lateral beating nystagmus. So it's sort of like if you don't look, you don't find. So you have to examine their eyes. The confusion can also be subtle initially. And it progresses. This is a progressive condition over a few months, sort of 2 to 6 months. But they may just seem a little depressed. They may stop talking. They may not forget how to use their cell phone or remote. That's one I had recently. And they'll just say, Mom just seems off. And then the ataxia, of course, again, you have to look for that. And commonly in the cases, medical legal cases I'm reviewing of Wernicke's, they didn't get the patient up to walk, either in the ER, in the hospital. You have to actually look at them walk. They may say, I'm having trouble walking. My legs feel like lead weights. But if you watch them walk, they're going to have this wide gait because they're unsteady and they walk slowly. And it's a classic Wernicke's gait. So why do these symptoms occur? Because you have to go back to thiamine functions. Thiamine is so important. And these are the 3 key functions. So it's in energy production. Yes, that Krebs cycle we all learned about was important. And so thiamine is a cofactor in several enzymes in the Krebs cycle, so production of ATP. So the first symptom they're going to have is a complete lack of energy. It's important for cell growth and function and myelin sheath maintenance, and that's why it essentially affects the white matter, all the nerves, and the brain. I have seen cases where patients go deaf or blind with Wernicke's. And so you think, oh, wow, there's so many vitamins we got to know as bariatric surgeons. So I really have to know this. Well, you do, because really thiamine deficiency is the only one that's an emergency. Sure, we have to monitor iron and vitamin D and B12 and other things, but they don't cause acute life-threatening problems and death the way thiamine does. So we really have to know this. And the reason it gets depleted so quickly is here. Thiamine is an essential micronutrient, meaning we have to take it from a vitamin or food. Our body does not produce it. The daily requirement, the more I read about this, I think this is actually undervalued. And I think the daily requirement probably needs to increase, and so many people are deficient. But this is currently the recommended daily allowance. It's 1.1 milligrams for women and 1.2 for men. But the body stores a very small amount and it has a short half-life. So it can be depleted in just 2 to 3 weeks. From the diet, thiamine-rich foods are pork is the highest. So pork, salmon, and several grains and some vegetables such as broccoli and asparagus. And so the pathophysiology, as I said, thiamine is a cofactor in the Krebs cycle, and disruption reduces ATP production, results in shunting the glutamine production, free radical production, which actually then breaks down the blood-brain barrier, and neuroexcitotoxicity. And these mechanisms eventually result in cell death. So we have to treat Wernicke's before those neurons die, because at that point, it's irreversible, and that's when you have Wernicke-Korsakoff's. There we go. And so there are symptoms of thiamine deficiency before it gets to Wernicke's, and it affects the whole body. And so the first symptoms someone's going to have, and they're kind of non-specific, it's fatigue, depression, some memory impairment, and they actually have anorexia and indigestion. So much like dehydration, if you're dehydrated, you feel nauseated, and it's kind of a vicious cycle, right? So nausea is a cause and a symptom of dehydration. It's much the same for thiamine deficiency. It's a cause of thiamine deficiency and a symptom of thiamine deficiency. And that's very important to remember. The muscles don't work as well. trouble breathing, fast pulse. And there's this old terms of beriberi, dry beriberi, wet beriberi, you may remember. So dry beriberi refers to the neuropathies that may have paresthesias. And wet beriberi refers to the cardiac symptoms if they may have tachycardia, acidosis. When you're out of the Krebs cycle, you actually produce more lactate, so they have a slightly high lactate. And that's the wet beriberi, and they can actually get a high output heart failure. So now if there's one thing you remember from my talk today, this is it. Wernicke's is a clinical diagnosis. You do not need any blood tests or any imaging, and they are not that reliable. And so the Kane criteria are now the diagnostic standard. When there's papers about Wernicke's, they always refer to the Kane criteria, and Kane published a paper in the 90s. And these criteria were validated in Wernicke's in alcoholics, but not Wernicke's in non-alcoholics, but it's still used as the standard. And so essentially it's that clinical triad plus dietary deficiency. And so all of our patients have dietary deficiency, right? Especially in those first 2 months. And the diagnosis of Wernicke's, you may be shocked to hear, requires 2 of dietary deficiency and then 1 of the classic triad, eye signs, cerebellar signs, and mild memory impairment. And using these diagnostic criteria, it has a sensitivity of 85% and a specificity of 99%. Wernicke's cases are rising, so it's more than unpublished cases of Wernicke's have more than doubled in the last 2 decades. It is clearly vastly underreported. And concomitant with the rise in bariatric surgery over the past 2 decades, there's been a rise in Wernicke's and a rise in Wernicke's malpractice cases. And as part of the task force, we're actually going to be looking at closed claims and Wernicke's within bariatric surgery, but much more broadly. There are other risk factors for Wernicke's, of course, alcoholism, and anything that gives you lots of vomiting. Hyperemesis gravidarum is another one, chemotherapy, and there are many other causes. So we're going to look at Wernicke's quite globally and educate other societies. And the way I'd like you to think of this is it's low frequency, high severity, much like DVTs, right? And we'll all focus now on preventing DVTs. And so everybody needs some prevention. So all of our patients need some thiamine, I think pre-op and post-op. The current ASMBS micronutrient guidelines, which are currently under review, they actually say to test everybody for thiamine and sort of be on the lookout. I think for thiamine deficiency, because it has been shown to be in preoperatively, a lot of our patients are deficient, which I'll get to. But probably what we really need to do is prevent it. Give everybody thiamine before surgery. That's what I do. I give everybody 100 milligrams a day orally for 2 weeks before surgery and continue for at least 6 months. And then they take a bariatric vitamin, which has 40 to 50 milligrams of thiamine versus a regular over-the-counter multivitamin has maybe 1 or 2 milligrams. So everybody needs routine low-dose prophylaxis because just 14 days can lead to irreversible brain damage. Then once they have it, so similar to VTE, right? We give low-dose prevention. Once they have Wernicke's, it's high dose, and it is a legitimate emergency, just like a PE, an MI, the white matter is dying and hours matter. So they have to be immediately admitted to hospital and given high-dose IV thiamine. So it's an emergency. You have to recognize it. There are a couple of published clinical guidelines on Wernicke's, one from England and another one out of Europe. And these were published like around 2010, and still it's under-recognized. And so it's recommended that you send off a blood level, but you don't wait for that to come back. It takes about 5 days to come back. You send a level, it's kind of academic, but you immediately treat. The first dose is stat, and you treat empirically without delay. And the treatment is high dose, so it's 500 milligrams IV, Q8 hours to 3 to 5 days. So they have to be admitted to hospital. You can't get this done as an outpatient. We probably could improve this, but infusion centers, they don't want to see people 3 times a day. You can't get this done at home. And you continue for at least 3 days, and then you continue till there's no further improvement. Signs and symptoms will start to improve within 24 to 48 hours. And if you've ever seen this, it's like, actually, I've seen this clinically a few times. It's literally like you're witnessing a miracle. The patient is confused. they can barely walk or can't walk, and 2 days later, their head clears, they can walk. It's quite impressive. And then one of the guidelines suggests that after 3 to 5 days, you drop down to 250 for a few days. But certainly once they have maxed out on the neurologic improvement, and then you continue them on 100 milligrams PO BID long term. Diagnostic tests are confirmatory only and are definitely not necessary. But if you're going to do them, it's got to be a whole blood thiamine. And then imaging-wise, a CT scan of the head will always be normal. So you'll get an MRI. Even then, even with contrast, it's got a fairly low sensitivity, around 50%. Eventually, the next slide will come. But these are what you'll see, and these are the most distinctive findings are in these areas here. The mammillary bodies, colliculite, periventricular gray matter, thalamus, and fornix. So they'll light up on these T2 weighted or SPECT images, and that is really pathognomonic. So if you see those, you've confirmed Wernicke's, but again, you don't need to do those. Occasionally, you'll see neurologic function tests done. Again, not needed, but on EEG, you'll see diffuse slowing, and that's in late stage Wernicke's. I've seen cases of this in the legal reviews I've done. And EMG, again, they have diffuse slowing because the white matter isn't functioning properly. Sadly, and this is clearly an opportunity for all physicians in all specialties, but certainly us in bariatrics, but 80% of patients with acute Wernicke's progress to Wernicke-Korsakoff syndrome, where they have persistent memory deficits, both antegrade and retrograde. They have deficits in learning. Classically, they confabulate, right? They don't remember things, so they fill in the blanks, they make up things. Rarely, I think probably never resolves. I did just find one perhaps case report I'm reading where perhaps someone improved. And often, and these are huge payouts medical legally because they will generally require permanent institutional care. And these go from being young, functioning people like you and I, and they end up in nursing homes, can't walk, don't know their kids' birthdays, and can barely feed themselves and tire very easily. If they can walk, they can't drive. So these are huge payouts that are easily avoidable. There are a couple reviews of Wernicke's in bariatrics. The first one was from 2008, and they looked at over 100 cases, and 84 had sufficient data to evaluate. And this occurs in all kinds of procedures. Thiamine is absorbed in the proximal jejunum, so of course the rerouting procedures like the bypass and the BPD are going to have higher rates, but you can, most of the cases, because sleeves are the most common now, most of the cases I'm reviewing are actually in sleeves. Most of them get admitted to hospital within 6 months of surgery, 94%. They have frequent vomiting as the most common symptom. And the vomiting lasted for a median of 21 days at admission. So that's, 3 weeks. That's your first or second post-op visit. They should not be vomiting. In MRI, only 40% sensitive, and about half of them had incomplete recovery. So if you treat the Wernicke's, they, early, that they will recover. If you don't, they won't. And memory deficits and gait problems are the long-term common sequelae. And they concluded that bariatric surgery training programs should include education on the possible nutritional complications of weight loss surgery. So here we are. And thiamine administration is advisable in all patients readmitted or reporting frequent vomiting after bariatric procedures. And it is simple, safe, inexpensive, and efficient. And there are very few complications reported of even high-dose thiamine. You mix it in 100 mLs of saline and you run over 30 minutes. There are very rare reports of anaphylaxis, but they are so rare that treatment should never be delayed. And I sort of view the prevention as primary, secondary, and tertiary, much like we look at many things in public health. So primary prevention, all our patients should be taking thiamine or at least a good quality bariatric vitamin. Secondary prevention, if they come to the ER with vomiting in those first couple of weeks, they need at least a banana bag. Banana bag has 100 milligrams of thiamine. And then tertiary prevention, once they have Wernicke's, you're trying to prevent further long-term sequelae of Wernicke-Korsakoff, so then they need the immediate treatment of 500 IV TID. So you can think of it that way. There's a more recent, published last year, in obesity surgery, literature review of Wernicke's after bariatric surgery from 85 to 2023. They used the PRISMA systematic review technique and reviewed 84 papers from a prior review by Udman plus 11 more, so 95 papers. And quoted another paper from ASMBS shows that, interestingly, up to 30% of our patients are deficient preoperatively. And I remember reading that paper, and I was shocked to find that. And apparently it's because it's thought to be because our patients' diets preoperatively are not great. And a high carbohydrate diet actually reduces thiamine. High carbohydrate foods don't have much thiamine, and they require more thiamine to metabolize. And so this is why probably a good idea we're all giving patients thiamine preoperatively, and our Wernicke's task force is going to be working with those other groups within ASMBS who are currently updating these guidelines. So we're working collaboratively with those to update these. And so in this paper, they looked at the 129 reported cases of Wernicke's after bariatric surgery, 65 were after bypass, and this paper is obviously going back many years. 29 after sleeve, 11 after gastroplasty, 8 after band, and 4 after BPD. Of course, this is vastly underreported. This is the tip of the iceberg. Prolonged vomiting, again, an important risk factor. They also concluded any patient with vomiting should be given IV thiamine with or before glucose. You probably remember that back from medical school and residency. You should give it with or before glucose, or it can precipitate Wernicke's. But if they're hypoglycemic, the guidelines say, administration of glucose should not be delayed, because of course that can lead to permanent brain damage also. And they found that the majority of cases of Wernicke's after bariatric surgery were quite early, 50% within 2 months and 80% within 4 months of surgery. And again, at this time, it is completely treatable and reversible. And they concluded early intervention and post-op supplementation is recommended to prevent Wernicke's. Okay, so a bit on to the medical malpractice. Eric's paper, of course, they looked at the top errors, causes of closed claims in bariatrics, and nutrition deficiencies were there at number 8 at 4.9%. And I think that's going to be increasing. These are the common breaches that I find in the standard of care when I am reviewing a case. And I review cases for both the plaintiff and the defense. And I think that's actually important to show that you're not biased. And it's important that we, we protect patients and surgeons and protect the field of bariatric surgery. And so these bottom 3 relate to Wernicke's, so delayed diagnosis, misdiagnosis. And then sadly, there's cases I've seen where people actually say Wernicke's, they make the diagnosis, but they undertreat. They give a banana bag, and it's not enough. That's like having someone come in with a PE and you give 40 of Lovenox once a day. I want you to sort of make that correlation in your head. And so this is what a typical case looks like of Wernicke's when I'm reviewing it. So say we've got a 43-year-old female with a BMI of 45, right? That's our classic patient, has a sleeve, discharged home post-op day 2 on a full liquid diet, selected to take a chewable multivitamin, but she struggles with intake after discharge. Then you get several ER visits. This should ring alarm bells in your head if the patient is coming to the ER several times. And sadly, in the cases I review, the patient gets labeled as non-compliant. Don't label the patient non-compliant if they're vomiting. They don't want to vomit, right? Nobody wants to vomit. They want to do well from their surgery and eat. And so typically, here we go. They present to the ER at 3 weeks with poor intake, nausea, vomiting, and weakness. They're given IV fluids. They feel a bit better. They're discharged home. They're back in the ER at 6 weeks. They can't keep anything down. They're weak. They may have had a fall. They're given IV fluids. Someone thinks they've got gastritis and they're discharged on Prilosec and Carefate. They tolerate some water and they're discharged again and says follow up with your bariatric surgeon. The bariatric surgeon may or may not have been called. Even I find when they are called, nothing different happens. Third visit to the ER, This should really ring alarm bells. They're coming by ambulance because they can't walk very well and they have dizziness. They're given IV fluids again, meclizine for vertigo, Zofran for nausea. They feel a little bit better. They're discharged with a walker. This is much like the case that Eric mentioned where the patient was discharged on home oxygen. That's not normal. If someone didn't come to hospital on oxygen, they should not be discharged on oxygen. And I find that to be a big flag in sepsis cases, which I think that patient did have a leak and sepsis. Discharge with a walker, big alarm bells. Then it progresses. 4th ER visit, again by ambulance as they can't walk. They're slurring their speech or not speaking much. And the family's concerned she had a stroke. They get a CT head. It's normal. They get admitted under the hospital list. Bariatric surgeons consulted. And the bariatric surgeon just says, oh, well, let's get an upper GI to look for a stricture. It's normal. So then the surgeon washes their hands, says, oh, the anatomy's fine. It's not my problem. It is your problem, right? Nutrition. We're the nutrition experts. It's always our problem. They suggest a psych consult and they sign off. Patients intermittently confused. Psych says they have a conversion disorder and they get discharged to a rehab facility. And I'm not making this up. This is exactly how the cases go. Patient never recovers, never gets thiamine, has Wernicke-Korsakoff's, poor memory, executive functioning, like they can't pay their bills. They now use a wheelchair, needs assistance with their ADLs, and they're permanently disabled with Wernicke-Korsakoff's, and there's a massive multi-million-dollar payout after the lawsuit. So if I were reviewing that case, my expert opinions would be, and of course they would need, in the actual case, they would get other experts for the other specialties, but that all the bariatric surgeon, the emergency physician, the hospitalist, and the psychiatrist were all negligent in failing to give thiamine in a high-risk patient. At that first ER visit, a banana bag probably would have done it. And from every visit onwards, they needed to diagnose and treat Wernicke's with high admission and high-dose IV thiamine. So in summary, give everyone, I think, thiamine pre and post-op for Wernicke's prophylaxis. We got to start calling it Wernicke's prophylaxis, just like DVT prophylaxis. Nausea is both a cause and symptom of thiamine deficiency. Most importantly, Wernicke's is a clinical diagnosis, right? Poor nutrition and one of the triad, it's Wernicke's. We all need to have a very high index of suspicion, even in the absence of any anatomic issues, and they get high-dose IV B1 if they meet the Kane criteria. I should say, of the cases I review for Wernicke's, probably half are purely Wernicke's and half, it's a secondary issue. Perhaps the patient had a stricture, had an anastomotic ulcer, had a leak, sepsis, in the ICU, and everything, you're just trying to keep them alive, and the nutrition gets neglected. And then they get, you save them from the sepsis, and then they have Wernicke's and Wernicke-Korsakoff's later. So give them high-dose thiamine in that situation. Thank you very much.
Thank y'all, Dr. Patterson and Dr. DeMaria. Those were fantastic talks. For the fellows, if you have questions, please put them into the chat or in the Q&A, preferably. We do have one question, that came up in the chat regarding, and I think it really to both of you guys, with the case, the review, Dr. DeMaria, that you did, and the case that you presented, Dr. Patterson, how do involvement of APPs affect claims, or how do you, navigate having APPs who extend us in the litigious space that bariatric surgery can be, so that we make sure that not only how we answer the phone is good and how when we give IV thiamine, but our most immediate support.
Yeah, so I can start on that one. And Dr. Patterson, great talk, so important.
Thank
you. That topic today in particular. But when it came to our review of cases that were closed claims, we didn't see any that were exclusively against APPs, but they were often carried along as co-defendants, so not immune from liability. But generally speaking, the cases were against the surgeon. And I was going to just maybe embellish just momentarily on Dr. Patterson's topic that communication plays a role in the thiamine deficiency issues that we see too. For example, I always like the case that I remember from years ago where every time the patient came in, they reported they were taking their multivitamin. However, they were promptly throwing it up. So you've got to make sure that if you're going to have somebody on vitamins, that they stay down, so you've got to have good communication.
Definitely. Regarding the APPs, yes, I would say I think more and more as they are, APPs, their numbers are growing rapidly and incorporating them and, they're into bariatric programs is increasing. I do see them named in lawsuits and, they are professionals too and have responsibilities. I agree with Eric. There's often a communication breakdown such that perhaps and perhaps sometimes over delegation. But say it may be in some practices, it's the APP who routinely does the first post-op visit at 2 or 3 weeks. I think if that's going to happen, I used to do that. That's perfectly fine. I see my own patients now. But I think that generally the role of APPs is supposed to be that they're seeing patients if everything is routine and going according to plan. And once it is outside that routine, there should be protocols that the surgeon is alerted, also sees the patient. A recent case I'm reviewing, currently reviewing as they do ongoing for years, as Eric said, is a patient, showed up at their first visit, said they're not keeping anything down, felt dizzy, couldn't drive themselves to the visit, had to take an Uber. Like if they're not back, they should be very highly functioning at 3 weeks. So communication is key there. And I'll see the classic breakdown in the Wernicke's is that, okay, they actually, good job, APP. You recognize this might be thiamine deficiency. And the classic mistake for APPs and surgeons is, let's send them for the blood test. Well, maybe they didn't feel well enough to even go for the blood test. It takes 5 days to come back. If you think it's Wernicke's, you just treat. You treat. Sorry to hammer that home so much.
It's really important, though, Dr. Patterson, as you
Yeah.
point out. I was going to say from my experience, clearly cases proceed against surgeons when there's never a documented low thiamine level.
Oh, yeah.
And a lot of times it's some neurologist months later who makes the diagnosis, and then, the malpractice claim gets filed. And I really love the way you put it. We are considered the nutrition experts. When we do bariatric surgery, the surgeon, and it's a reasonable assumption, should be thought as the nutrition expert for the bariatric surgery procedure specifically.
Yep.
Dr. Dan, I know you have a question, considering we're getting to the end. Let's get your question next, and then I have a couple.
Quick comment and a question. So I remember.
Oh,
We'll forgive you for any mistake.
You're freezing up a bit there. Is he freezing for you guys?
Yeah, he is. Maybe I can phrase it. I do know he was interested, Dr. Patterson, is specifically asking you about with this new the new medications for GLP-1s and anti-obesity medications. Is this an area where we're going to start to see Wernicke's encephalopathy because we've put out medications that are very effective in treating obesity by telling you how to feel about food, but we're not giving them maybe the adequate dietary and nutritional support long-term in parallel? Love to hear your comments.
Yeah, absolutely. So actually I did a webinar for the APPs for ASMBS last spring, I think it was. And I predicted on that talk, I said, we're going to start seeing Wernicke's from the medications now. We have to get this word out to everybody. Sure enough, now in the last 3 months, I'm actually reviewing 2 cases of Wernicke's that are from the medications. And we really have to get the word out fast because this is going to be rampant. There are no warnings about nutritional deficiencies or Wernicke's on the labeling for the medications. Every PCP and Tom, Dick, and Harry is prescribing this stuff. Now, I'm not even sure how this is allowed or legal, but the manufacturers are going to start just sending it out to patients on their own without a provider. I have heard. I don't know how they're allowed to do that, and we need to push back against that and educate everybody because Yes, in fact, it's one of the cases I'm reviewing. It's one of the most brutal cases. And I mean, of course, some people die. I mean, this is untreated. 20% of people with Wernicke's will die, I should have said. But, you know, perhaps worse than death is to be permanently maimed. And one case that I am reviewing, I mean, they've actually sent me a video of what the patient is like now. And she was a high functioning woman enjoying life. And now she is bedbound. She can't walk at all. Her arms are kind of twitching. She can speak, but very slowly. It's hard to understand her. It is very sad to see and completely preventable. Yeah, we're going to see a lot more.
I think that hits a really good point, and actually part of it's maybe I'm going to tie it very loosely. We need to be paying attention for sure to you know, these patients coming in with AOMs are interested in it. I think one of the things that would be beneficial that we're hearing a little bit in North Carolina is, should we be doing it similar to bariatric surgery in the setting of multidisciplinary approach? Use a dietitian to evaluate them, potentially even if you have the resources, psychology or social work, but approaching them not just by the medical provider, but by a nutrition expert as well, so that we're at least teaching them that you're not going to feel like it, but you're going to need to eat. And if your nausea is so bad, you need to let us know. But then also, maybe we need to put them all on multivitamins over the counter while we're figuring out what the kind of natural progression is going to be with GLP-1s. As we learn, we're going to see more seizures, we're going to see more hair loss, and we're going to see more B1 in the news, or I think Wernicke's symptoms in the news.
Yes. Actually, I think, I mean, more than an over-the-counter multivitamin, again, that only has 1 or 2 milligrams of thiamine. I mean, I think that need it, and I think that's a very good point. These people likely should be treated in the multidisciplinary programs that we have as surgeons with dietitians, but I think they need at least a bariatric quality vitamin, which generally has at least 40 milligrams of thiamine, and probably just put them on the 100 twice a day. Let's just prevent this thing.
Yeah,
You know?
so I mentioned before when we were talking that our program now we have IV thiamine in the office, and that was very intentional. It took me over a year to get it approved, and we don't start IVs in our office, so I can't put an IV in, but I can give them a shot. So what our approach is, we draw the blood and give them an injection of thiamine during that same visit, and then we start bringing them back for injections until we figure out if thiamine was the issue.
Yeah, you give them IM. Yeah, and of course, you know, you mentioned the blood test, but again, the blood test is not where it's at. It's even not, you know, because what really matters is the CSF level of thiamine. And nobody's looked at that, you know, lumbar punctures to see the CSF level. So the serum level doesn't really correlate at all. The whole blood level is more significant. But, you know, if they've taken a vitamin or had a banana bag, I mean, the number's irrelevant. It's a clinical diagnosis.
And I should probably point out, I'm not talking about the full-blown Kane criteria.
Yeah.
Here, you know, if you have those, you bring the patient into the hospital and treat them. I'm talking about people who have nausea, vomiting, and they don't feel particularly good, no nystagmus, you know, you're not really sure.
Yeah.
But we have to have that high index of suspicion and begin treatment empirically.
Yes, exactly. So they're thiamine deficient, but don't yet have Wernicke's. Exactly. And I am shot in the office or a banana bag. And what we do is there's places that go, mobile places that will go give them a banana bag. Well, like, okay, you just call up for a banana bag. In those first few weeks, that's fine. Once it passes 2 months and they have any of those symptoms, then it's like admission.
Yeah. All right. Well, thank y'all very much for this robust discussion. I learned a lot. There's some really interesting resources to Dr. DeMaria's points on communication. If you go to the AHRQ's website, Team Steps is a funded educational opportunity for how to communicate in the OR with teams. But I think my final kind of comment, we are trained to be surgeons. We're not trained to be team leaders or team captains. And figuring out how you're going to communicate before things happen will improve and prevent problems in the back end. So you stay out of the courtroom and Dr. Patterson doesn't have to defend you. And then I think the last takeaway here would be always have a high index of suspicion. If you're thinking nausea, vomiting, give them thiamine before it becomes a problem to prevent the really scary stuff from happening. And on that note, I'll give it back to Dr. Dan.
Thank you very much. I think we hit all the points. This was fantastic. I think one of our best sessions, and we'll see you all this afternoon for the afternoon West Coast session.
All right. Thank you, guys. Thanks for having me. Bye-bye.
All right, so I'm Judy Chen at Seattle University of Washington, and I just want to thank Dr. Patterson, Dr. DeMaria for, as Dr. Adrian said today, incredible cases, discussion points for the fellows. Happy birthday, Dr. Patterson.
Thank you.
And we appreciate both of you returning after early morning presentation. So there is a question from Jeff Hodges. His question is for Dr. Patterson. The question is, how do we balance mitigation of personal risks for post-operative vitamin deficiencies with lack of insurance coverage, lack of patient follow-up, completing some of these labs? He goes on to say, recent systematic review meta-analysis show thiamine deficiency is most common early with rapid weight loss, yet testing is not often covered in this phase post-operatively.
Okay. Simple answer, don't test. Just give it to everybody. It's not that expensive. We carry, to make sure that patients get the good quality vitamins, the appropriate vitamins, we carry them in the office. We actually include the package for the first 3 months. It's currently free as a 2024 special. And so when I was saying, we put them all on 100 of thiamine for 2 weeks pre-op and 6 months post-op, we provide that. And then it's debatable whether they need more after that. We have them take the bariatric quality vitamins and encourage them to just keep renewing those. So I personally never order thiamine. I shouldn't say never. The only time I don't order thiamine levels routinely in the office at all. The only time I'm ordering a level is if I'm sending someone to the ER and calling them and saying this patient needs admission and first dose 500 IV thiamine stat, I'm like, you can send a whole blood thiamine, but don't delay giving the thiamine. And that really is the only time I order it. So it's giving the thiamine is much cheaper than doing the test. And I forget how much it costs, but just sell it right there in the office or give them for the first month.
I think it's really interesting. Well, actually, let me take a step back and thank both of you guys for coming. I think, these topics are really important. And as I'm listening to the presentations, which were awesome, I'm also a little nervous, just thinking about the topic. But you mentioned, Dr. Patterson, about the emergency room physician being potentially negligent in that case. Do you think that there's a role for the bariatric surgeon in managing these patients as soon as they come in? Like, do you think it's our responsibility to actually tell the ER physicians as soon as the patients hit the ER, they need to get the thiamine right away?
Absolutely. And this is part of our, our mission in the task force is that we realize that, I think that we are the most responsible, as I've said, but typically in these cases, it's just like that. There's at least 4 different specialties who missed it. And so we're going to educate the ER docs, the neurologists even miss it, the hospitalists miss it, 10 different doctors have missed it in these cases. So we do. And, it's not that easy still. Like there is such a lack. It's shocking to me that there's such a lack of knowledge about such an important thing that's so easy to prevent and treat. So when you do send someone to the ER, it's not easy, I admit. You got to plan on speaking to and educating 3 different doctors. So I'll say, hey, this person's coming in. And I know you're going to think this is weird, but I'm kind of an expert on Wernicke's as a bariatric surgeon, and they have Wernicke's. And it's a clinical diagnosis, and you just go through all the thing, like just treat it. And there was maybe some pushback, they're getting to know now around here. And then 3 hours later, I'll get a call from the next ER shift doctor, like, oh, what are you saying? Like, no, really admit them, call the hospitalist. And then 3 hours later, get another call. So we're going to have to champion this, but you have to be very proactive. I had one literally last week who I was just, she had a bypass by me 10 years ago. I hadn't seen her in 2 years, but at that time, 2 years ago, she had a small anastomotic ulcer that we were treating, and she was supposed to follow up with me in 2 months for another scope. And despite many calls, she didn't follow up. And then I was just getting through the Epic EMR, these messages from, oh, your patient's been discharged with dizziness, with weakness, with numbness and tingling. I'm like, oh my God, she's got Wernicke's. So I get my MA to get on the phone with her, and he tries for weeks to get a hold of her. We eventually do. She lives out of town. We send her to the ER. And I say, look, this is what you've got. You tell the doctor to call my cell phone. You need admission, blah, blah, blah. They didn't. They actually told her they called me and they didn't. They called another bariatric surgeon who gave her a banana bag. So now the test would be useless anyway. Now there's no point testing, and sent her home. So I literally have to be so proactive. I got up in the morning, I checked. She hadn't been admitted. So we get back on the phone. We send her over to my hospital. She's got to drive 3 hours. I tell them she's coming. They're getting used to me calling them with these cases. And we got her admitted. And literally, so she'd had some confusion. She had difficulty walking. She clearly had it. She had a little mild nystagmus. And then in the ER, because this has been going on for a couple months, she literally, her right leg became very weak. She couldn't even lift it off the stretcher. So their thing is she's having a stroke. I'm like, she's not having a stroke. Go ahead, CT, MRI. And we give the high-dose IV thiamine. I go see her 2 days later. She's better. She's gone from a 3 to 5 strength to a 5 to 5. And still, she tells me the doctors don't believe that's what she has. I'm like, well, I've written this big note educating them. I'm like, what do they think you have? It's just a miracle. What else have they done to treat you? They've MRI'd her spine. Everything else is normal, and they still don't believe it. So that's what we're up against. Sorry for such a long answer.
That's
we
okay.
absolutely have to be the champions of this.
So let me ask both of you guys this. If you, as a bariatric surgeon, find yourself in one of these precarious situations, where you're being sued, for instance, how do you manage it, especially for the people coming out into practice, within the next few months? What would you advise them to do?
So you immediately, of course, if you're handed a lawsuit, you immediately call your insurance carrier, right? And you don't change the record. I see that happening too much. You don't change a record. You call your insurance carrier. They're going to assign you an adjuster. And these people are great. They're really experts, and you get their number and you call them. Because first of all, it's frightening. You feel horrible. You're angry. You're sad. And they're going to talk you down off the ledge, first of all. And they're going to support you. Okay. Then they're going to get you an attorney, and you don't talk to anybody else about it other than your spouse. So that's first. Yeah. Eric, your comments on that?
Yeah, I would just want to chime in that we as physicians don't really think about this the same way that lawyers think about this. This is a business issue for patients and lawyers. And we take it so personally that someone would question us. So often, the motivation is just the patient wanting to understand what happened to a loved one, what happened to themselves. And when they don't get answers, they're motivated to file a suit to try to figure it out. And we have to stop taking it so personally. It's a business proposition. And you need to defend yourself intelligently and rationally, and not emotionally when you get into this situation.
You're, I think, muted, Dr. Patterson. Maybe.
Check this out. Can you hear me now?
Yeah.
Okay, say that. So I've been sued a long time ago, and it does feel personal. It's heartbreaking, and it goes on for years. So, get in therapy, all those things, make sure you got a good lawyer. But, most importantly, prevent it, right? And I think I wanted to say a word about that. And there's, I think, I kind of try to follow life by the 4 agreements. And, one of them, first one is don't take it personally. Be impeccable with your word. Like, always tell the truth. The patients, the doctors, the attorneys, when you're being deposed. I read depositions all the time where the doctor's clearly lying or saying something ridiculous. Just tell the truth. Don't make assumptions. And above all, always do your best. So we're all going to have complications. Just don't bury your head in the sand, run away, do the hope and a prayer technique that the patient's going to get better on their own. They're not. So it happened. Still be a good doctor, still be a good surgeon. If you keep making every decision that's correct, doing the best for the patient, you're not going to lose a lawsuit. I'm never going to be critical when I'm on the plaintiff side that anything got injured, perforated, anything. Injuries can happen. It's what you do next. That's the key.
Yeah, really, again, appreciate fantastic discussion today. your insights, your experience, the opportunity. I hope the not residents, the fellows, and anyone in the audience can really tell that I think we do have the power to take care of patients, be the advocate, and move our practice forward in bariatrics. So thank you both. Really appreciate all the insight.
All right. Thanks for having me. We really appreciate it. Spread the word. Passionate about it, as you can tell. All right, have a good day.
I'm going to start prophylactic thiamine for sure.
All right, do it. All right, take care. Bye-bye.
Thank you, guys.